Looking at a radiograph in the morning trauma meeting, there is usually this expectation of consensus, isn't there?
Yeah, absolutely. There's a definite routine to it.
Right. I mean, it provides a certain rhythm to the start of the day. A displaced midshaft femur fracture appears on the screen, and the room implicitly, straight away, prepares for intermedullary nail.
Right.
Or, we see an unstable extraarticular distal radius fracture in a high-demand, physiologically young patient, and the discussion immediately shifts to the templating of a volar locking plate.
Because the algorithms for those injuries rely on highly predictable biomechanical solutions.
Exactly. The room agrees because the mechanics basically dictate a singular, mathematically sound structural fix.
Yeah, the structural solutions for those diaphyseal or simple articular fractures are essentially binary.
Right.
I mean, the mechanical disruption is identified, the vector forces are calculated, and the rigid osteosynthesis applied achieves a highly predictable union rate.
Which makes the discussion quite straightforward.
Quite. The debate is relegated to minor technical nuances, not the overarching philosophy of care.
But the moment a complex proximal humeral fracture flashes onto the monitor, that entire consensus just shatters.
Oh, completely. It's chaos.
It really is. Suddenly, a room full of highly trained orthopedic trauma surgeons fractures into three fiercely opposed camps.
Spot on.
You'll have one consultant who will advocate for immediate open reduction and internal fixation with a locking plate, citing the absolute need for anatomical restoration.
Right.
Then another will argue aggressively for conservative management at a broad arm sling, perfectly willing to accept, a varus deformity just to avoid surgical morbidity.
Yeah, the minimalist approach.
And invariably, a third will sit quietly in the back, pulling up the templating software for a reverse shoulder arthroplasty, entirely convinced the biology is already dead.
It is the absolute definition of therapeutic chaos.
It happens in every major trauma center in the world, doesn't it?
Every single morning. Proximal humeral fractures remain the single most controversial fracture pattern in upper limb trauma surgery.
Without a doubt.
I mean, the literature is a minefield of conflicting data, and the margin for error is razor thin. We are not just debating surgical philosophy here.
Right, we're talking about livelihoods.
Exactly. We are dictating a patient's entire functional future. The management decision made in the acute setting, within those first few days of the physiological inflammatory response is the definitive variable.
It alters their whole long-term trajectory.
It really does. Get that initial management right, and you restore independent function.
Yeah, but if you get it wrong,
Misjudge the biology or the mechanics, and you condemn the patient to a cascade of catastrophic failures, culminating in the dreaded, heavily morbid need for salvage reconstructive procedures.
which is exactly our mission for this deep dive today.
Yeah.
We're going to equip you, the orthopedic trauma surgeon, the upper limb fellow, or the emergency physician navigating acute admissions with a rigorous, evidence-based decision framework.
Because we have to cut through that noise.
Absolutely. We're spanning the intricate biomechanics of non-operative care, the specific vector challenges of internal fixation, and, of course, the extreme anatomical demands of complex arthroplasty.
Right.
We have to navigate the myriad of conflicting guidelines that currently dictate practice. Because before anyone can even think about prepping a patient, picking a surgical approach, or opening an implant tray, you have to truly understand the fracture.
Morphologically and biologically.
Yes. And that forces us to look at the evolution and, frankly, the glaring clinical limitations of how we classify these injuries in the first place.
Yeah, because you cannot effectively treat a pathology that you do not accurately conceptualize.
So true.
For decades, our conceptualization of proximal humeral trauma has been deeply systematically flawed.
But what specifically?
By an over-reliance on superficial radiographic appearance rather than underlying physiological viability.
Which brings us right to the legacy of the Neer classification. I mean, established in 1970, it is the granddaddy of them all.
It is indeed.
It divides the proximal humerus into four anatomical segments.
Yeah.
Right? The greater tuberosity, the lesser tuberosity, the articular segment, and the humeral shaft.
Yeah.
And displacement is rigidly defined by that classic, almost dogmatic rule, more than 1 centimeter of translation or 35 degrees of angulation.
The classic criteria, yeah.
And then we have the AOTA classification, offering this incredibly granular alphanumeric code based on fracture location and morphology.
Which looks great on paper.
It does. But I look at the inter-observer reliability studies for Neer, where the kappa values frequently hover around, 0.3 or 0.4?
Yeah, it is essentially coin flipping at that point.
Exactly. I mean, relying purely on morphological classifications like NEAR or the AO system is like describing a severe high-speed motor vehicle collision
Yeah.
purely by the dents on the outer doors
Yes.
without ever checking to see if the engine block is actually cracked.
That is a brilliant analogy.
Thanks. I mean, these traditional systems, are they actually failing clinicians by completely ignoring the biological viability of the articular segment?
The data supports that entirely. They are failing us clinically if they form the sole basis for surgical decision-making.
Right.
Now, the NEAR classification provided a necessary common language half a century ago.
Which was revolutionary at the time.
Absolutely. It allowed a surgeon in London to communicate with a surgeon in New York, conveying that a three-part fracture involved the surgical neck and one of the tuberosities.
A shared lexicon.
Exactly.
Right.
But what NEAR fundamentally fails to do, and what the AOTA system also struggles to quantify in a busy acute trauma day, is predict vascularity.
Which is everything.
It is. They describe the geographic three-dimensional arrangement of the osteochondral fragments, but they offer zero insight into the intraosseous perfusion of the articular head.
And when you're deciding whether to preserve the native joint with osteosynthesis or resect it for an arthroplasty, perfusion is basically the only variable that dictates long-term survival.
Exactly. Because if the arterial supply to that humeral head is disrupted, you can execute the most beautiful, radiographically flawless, biomechanically rigid osteosynthesis imaginable.
The perfect X-ray.
The perfect X-ray. But it is entirely futile. The bone will inevitably collapse into a vascular necrosis.
Because you are meticulously affixing dead bone to live bone.
Right. The failure is biologically predetermined.
Wow.
This is exactly why the transition to Hertel's binary description and vascular risk criteria back in 2004 was such a monumental paradigm shift in shoulder trauma.
Let's unpack Hertel's criteria, because it really changed the game, didn't it?
It absolutely did. Hertel moved the specialty away from this obsession with counting parts and forced an evaluation of the anatomical predictors of ischemia.
Right.
He presented a framework that demands a binary physiological answer. Is the blood supply to the humeral head compromised or intact?
The physiological anatomy here is just fascinating, especially considering how our understanding has evolved over the
Oh,
years.
completely.
Historically, the dogma was that the anterior circumflex humeral artery, the artery of laying, was the dominant vascular supply to the humeral head.
Yeah, we base decades of surgical approaches on protecting that single vessel.
Right. But modern cadaveric and highly detailed perfusion studies completely upended that.
They prove that the posterior circumflex humeral artery actually provides the critical dominant intraosseous perfusion via the arcuate artery.
But the problem is, on a standard trauma series radiograph or even a fancy 3D CT reconstruction, you cannot visualize those circumflex vessels.
No, you can't see the soft tissue at all.
So you have to evaluate the bony proxies that protect them. And the most crucial proxy in the proximal humerus is the medial hinge.
Yes, the medial hinge is the absolute cornerstone of acute fracture assessment.
Explain the medial hinge for us in this context.
So it refers to the medial cortex of the proximal humerus, specifically that highly dense bone of the calcar region.
Good.
The ascending branches of those circumflex vessels run perilously close to this medial periosteum. When the bone fractures, if the medial hinge remains intact, meaning the medial cortex of the articular segment is not significantly translated or angulated away from the medial cortex of the diaphyseal shaft, the periosteal sleeve on that medial side often remains in continuity.
So it's basically acting as a bridge.
Exactly. That intact periosteal hinge acts as a physical tether, protecting the delicate microvasculature.
And Hertel's data demonstrated a specific cutoff for this, didn't it?
He did. He showed that if the medial hinge is disrupted by more than 2 millimeters of displacement, the shear forces tear those vital vessels.
Just 2 millimeters.
Just 2 millimeters. And at that point, the risk of AVN transitions from a mere possibility to a very high probability.
And he paired that 2 millimeter displacement rule with a highly specific measurement of the metaphyseal extension, right? The calcar length attached to the head fragment.
Yeah, the metaphyseal extension is the second critical variable.
How does that play into the perfusion?
Well, if the fracture line propagates directly through the anatomical neck, leaving absolutely no metaphyseal bone attached to the articular segment.
So basically a calcar length of 0.
Or anything less than 8 millimeters, really. If it's less than 8 millimeters, the intraosseous network is almost universally severed.
Wow.
Therefore, when evaluating a multiplanar CT scan and identifying a true anatomical neck fracture with a completely disrupted medial hinge, where the diaphysis is translated laterally,
Right.
you are looking at an inherently ischemic, vascularly dead piece of bone, regardless of the patient's age.
So incorporating Hertel's criteria completely alters the cognitive approach to the preoperative assessment.
Completely.
You stop looking at the 3D CT reconstruction as a morphological jigsaw puzzle trying to fit Near's definitions.
Yeah, you stop counting parts.
Exactly. Instead, you actively interrogate the scan for perfusion markers. You measure the metaphyseal extension down to the millimeter, you evaluate the integrity of the medial periosteel sleeve, and you scrutinize the calcar.
Right, because this biological assessment instantly dictates the logistical surgical plan.
It dictates the entire trajectory of the intervention, really.
It determines whether you are calling for the proximal humeral locking plate instrumentation or whether you need the revision arthroplasty sets opened and templated.
Because respecting the medial hinge is synonymous with respecting the biology of the joint.
Spot on.
But understanding the fracture pattern and predicting its biological viability is the foundation. It only addresses half of the clinical dilemma.
Right.
The subsequent and arguably far more contentious question is whether surgical intervention is indicated at all.
Ah, yes. The big debate.
Which brings us directly to the most heavily scrutinized, practice-altering, and fiercely debated trial in modern orthopedic shoulder trauma.
The Proffer trial.
The Proffer trial, published in 2015.
Yeah.
I mean, this was a massive, multi-center, randomized controlled trial directly comparing surgical intervention versus non-operative management for displaced proximal humeral fractures.
It was huge.
Upon publication, it sent absolute shockwaves through the global orthopedic community.
It really did. Overnight, it drove a massive pendulum swing in clinical practice, heavily favoring non-operative management.
Because the primary outcome data suggested that at a 2-year follow-up, there was no statistically significant difference in the Oxford Shoulder Score or general quality of life metrics, whether the patient underwent surgery or was simply placed in a sling with structured rehabilitation.
Right. Which sounds incredibly definitive on the surface.
It does. However, we had to interrogate the methodology and the downstream application of this data. Did the orthopedic community overcorrect?
I believe we did in many ways.
If a trial explicitly excludes the absolute worst-case scenarios, the true head-splitting fractures, the profound fracture dislocations, should its conclusions be weaponized to dictate universal, rigid departmental protocols?
That weaponization of RCT data without context is a profound issue. It really requires a highly nuanced dissection of the Proffer methodology.
Let's dissect it then.
First, we have to acknowledge the critical positive disruption Proffer achieved.
Fair point.
Prior to 2015, the advent of locking plate technology created an alarming plate fixation for all mentality.
Everyone was getting a plate.
Everyone. And we were witnessing unacceptably high complication rates, primary screw cutout from osteoporotic bone, secondary varus collapse, deep intra-articular infections, and devastating secondary stiffness.
And these were in fracture patterns that historically would have united beautifully with conservative management.
Exactly. Proffer provided high-level evidence that non-operative management is not merely a fallback, but a highly viable primary strategy.
Right.
And it yields comparable expected functional outcomes for a massive cohort of displaced fractures. It spared thousands of vulnerable patients from surgical morbidity and the inherent iatrogenic risks of the delta pectoral approach.
So it provided the empirical backing needed to confidently review, say, a 72-year-old patient with a displaced 2-part surgical neck fracture with acceptable alignment.
Yeah.
And definitively state that the physiological burden of a major open operation is simply unjustified.
Exactly.
The functional outcome with structured phased rehabilitation will equal the surgical outcome, minus the risk of a catastrophic deep infection or implant failure.
That is the precise clinical scenario where Proffer shines.
Right.
But the critical flaw in the post-publication interpretation lies in the trial's explicit exclusion criteria.
The dogma of never operate on a proximal humerus fundamentally ignores who's actually enrolled in the trial.
Quite right. The trial deliberately excluded severely displaced fractures, highly complex comminuted patterns, fracture dislocations, pathological fractures, and patients with profound neurological deficits.
So a huge chunk of the complex trauma bay presentations were never even studied.
Exactly. Crucially, the trial design hinged on the concept of clinical equipoise.
Equipoise. The treating surgeon had to genuinely be uncertain whether surgical or conservative treatment was a superior option for that specific individual.
Yes, and the concept of equipoise is the linchpin of the entire debate.
Explain that, because when a trauma surgeon reviews a radiograph of a severely displaced, completely unstable four-part fracture,
Right.
where the greater tuberosity is retracted superiorly by the supraspinatus and the lesser tuberosity is pulled medially by the subscapularis, completely obliterating the rotator cuff mechanics. There is zero clinical equipoise.
None whatsoever. The surgeon knows unequivocally that the fracture requires mechanical reduction and fixation to restore the vectors of the glenohumeral joint.
Those severe mechanics-destroying patterns were never randomized into the Proffer cohort.
They weren't. The trial robustly investigated the clinical gray zone, the moderate displacements where the mechanical disruption did not automatically spell functional doom.
Right.
It absolutely did not investigate the black and white extremes.
But applying Proffer guidelines universally became an administrative trend in many healthcare systems, mostly to reduce surgical volume, didn't it?
Sadly, yes. And doing so actively ignores the immutable laws of orthopedic biomechanics.
Consider a highly comminuted varus angulated surgical neck fracture with absolute loss of medial cortical support.
Yeah, picture that mechanical arrangement.
Placing that specific fracture in a broad arm sling does not result in benign healing.
No, it guarantees catastrophic varus collapse.
A high probability of hypertrophic non-union.
And a massive permanent functional deficit due to the shortened moment arm of the deltoid.
So this specific nuance empowers the surgeon to aggressively defend their operative indications during multidisciplinary team meetings.
Absolutely. Or when facing pushback from clinical governance boards citing superficial interpretations of the Proffer abstract.
You can articulate precisely that Proffer validates conservative management for the moderate equipoise cohort.
Right.
But it does not repeal the basic principles of biomechanical vector restoration for severely displaced, structurally unstable variants.
You are treating the specific mechanical disruption of the individual patient, not blindly adhering to a population-level aggregate. If the tuberosities are displaced to a degree that the rotator cuff force couples are uncoupled, or if the articular head is dislocated from the glenoid vault,
surgery isn't just an option.
It transcends being an option. It becomes an absolute physiological necessity to restore any semblance of functional glenohumeral kinematics.
So, having established that Proffer cannot be blanket applied to the complex extremes, and that certain mechanical disruptions absolutely mandate surgical intervention.
Yes.
The focus then shifts to the execution of that surgery.
Which brings its own set of massive debates.
It does. We rely on a highly tailored surgical armamentarium. And the primary variable dictating the selection from that armamentarium is the biological age, bone mineral density, and functional demand of the patient.
Right.
Let's define the strict parameters for the under 60 algorithm.
Okay.
We are evaluating a patient under 60 years of age with high occupational or recreational demands and robust physiological bone stock.
A very specific, unforgiving demographic.
In this specific demographic, the overriding, non-negotiable goal must be joint preservation whenever anatomically and biologically feasible.
Absolutely. In the under 60 cohort, primary arthroplasty, while occasionally forced upon us in cases of catastrophic head-splitting trauma or true anatomical neck fractures with massive extrusion, must be viewed as the absolute final resort.
Because implanting a shoulder prosthesis in a 45-year-old manual laborer imposes a lifetime of severe load restrictions.
Right. And it carries the statistical certainty of future highly complex revision surgeries due to glenoid component loosening or polyethylene wear.
Therefore, the surgical imperative is joint preservation through open reduction and internal fixation.
Or IF is the gold standard there.
And the arsenal for joint preservation primarily involves proximal humeral locking plates and modern intramedullary nailing systems.
Yeah.
The biomechanical rationale for choosing between these load-bearing versus load-sharing devices is incredibly nuanced. Let's start with the workhorse of the last 2 decades, the proximal humeral locking plate, specifically the Philo system and its various iterations.
Right. The advent of the fixed-angle locking plate fundamentally revolutionized the management of osteopenic metaphyseal fractures.
Because standard non-locking plates relied on friction between the plate and the bone, right?
Exactly, which inevitably failed in the cancellous void of the proximal humerus. There's just nothing for the screws to bite into.
So the locking plate functions as an internal fixator.
Yeah. The threaded screw heads lock directly into the plate, providing angular stability that maintains purchase even in regions of compromised bone mineral density.
And the primary indication for this.
A displaced two-part, three-part, or reconstructible four-part fracture where Hertel's criteria suggest the articular head remains vascularly viable.
Yet the locking plate is notoriously unforgiving.
It really is.
It fights a constant battle against the biology of the fracture hematoma and the mechanical threat of varus collapse. So how does the surgeon meticulously balance the requirement for rigid biomechanical fixation with the imperative to avoid devastating biological stripping?
That balance honestly defines the true art of complex shoulder trauma surgery.
It's a tightrope walk.
It is. The standard delta pectoral approach provides excellent extensile access to the anterior and medial humerus, but it requires meticulous, deliberate preservation of the soft tissue envelope.
Because the blood supply to the tuberosities and that critical medial hinge must be respected.
Right. If a surgeon aggressively strips the periosteum bare simply to achieve a perfectly reduced anatomical X-ray, they have effectively caused iatrogenic avascular necrosis.
The biology has been sacrificed for the radiography.
Precisely. Biomechanically, the single most critical intraoperative step when applying a lateral locking plate is the restoration and rigid support of the medial column.
Because the plate sits eccentrically on the lateral cortex.
Exactly. So a commanded medial calcar subjects the plate to immense cyclic bending forces with every single contraction of the deltoid.
If the medial column is not supported, the construct will fail into varus.
It's guaranteed. This is precisely where calcar screws those specific inferomedially directed locking screws designed to buttress the dense bone of the medial humeral head are non-negotiable.
They effectively neutralize the varus bending moment.
They prop the whole thing up.
Now, what about the role of intramedullary nailing? Nails largely fell out of favor during the initial surge of locking plate popularity, didn't they?
They did, yeah.
But modern, straight, multiplanar interlocking nails are experiencing a massive resurgence. Where do they fit into the algorithm for the physiologically young patient?
Intramedullary nails offer distinct biomechanical advantages for specific fracture morphologies,
Like which ones?
particularly displaced two-part surgical neck fractures or specific three-part patterns without massive greater tuberosity comminution.
And what's the biomechanical advantage there?
The profound mechanical advantage of a nail is that it functions as a load-sharing device positioned directly within the central biomechanical axis of the humerus.
This contrasts sharply with the load-bearing lateral plate.
Exactly. Because it sits centrally, the bending moments are vastly reduced. Furthermore, nailing is achieved through a significantly smaller, less invasive superior approach, which preserves the fracture hematoma, avoids massive periosteal stripping of the diaphysis, and protects the radial nerve.
It sounds ideal, but the inherent trade-off is the entry point morbidity, isn't it?
Yes, that's the catch.
To introduce a rigid, straight nail down the humeral canal, the surgeon must violate the rotator cuff footprint.
The entry point is the Achilles heel of intramedullary nailing in the proximal humerus.
You must incise directly through the critical zone of the supraspinatus tendon, or precisely through the rotator interval.
Right. And in a high-demand 50-year-old patient, violating the rotator cuff creates a significant risk of long-term postoperative shoulder pain and cuff dysfunction.
Especially if the footprint is not meticulously repaired.
Or if the proximal end of the nail is left proud, impinging on the acromion. That's a classic complication.
Additionally, controlling severely displaced, comminuted tuberosities with a nail historically proved far more challenging than with a plate.
It did, although modern nail designs featuring proximal locking screws with screw-in-screw technology have vastly improved tuberosity capture.
We have to evaluate the stakes of this decision matrix, though. The central thesis of upper limb trauma is that the most critical decision is the first one.
Always.
Let's detail the clinical reality of a failed primary ORF in a 55-year-old patient. What is the exact cascade of events when the biological assessment was incorrect or the mechanical fixation was inadequate?
The failure cascade is devastating and it's rapid.
Walk us through it.
Consider a scenario where a surgeon pleats a complex fracture that violated Hertel's criteria, a highly displaced fracture with a disrupted medial hinge and minimal calcar length.
So it's doomed biologically from day one.
Exactly. 6 to 12 months post-operatively, a vascular necrosis inevitably develops.
Right.
The osteonecrosis causes the cancellous bone of the articular head to resorb and structurally collapse. However, the fixed-angle titanium locking screws, rigidly secured into the lateral plate, do not move.
They stay exactly where you put them.
They do. As the humeral head collapses into varus around them, the tips of those screws penetrate the articular cartilage.
Ah, this is the dreaded pecker effect, or
Yeah.
secondary screw cutout.
Right. Now, with every degree of glenohumeral motion, rigid titanium screws are directly grinding against the native articular cartilage of the glenoid vault.
Oh, the clinical presentation for that is unmistakable.
It's true.
The patient presents with agonizing mechanical pain, audible crepitus with any rotation, and a rapidly deteriorating functional arc of motion.
The glenoid cartilage is destroyed within weeks.
Wow.
You are now faced with a 55-year-old patient who has profoundly destroyed glenoid bone stock, a severely distorted proximal humeral metaphysis, heavily scarred and adherent soft tissues, and a joint filled with metallosis from the grinding screws.
You have converted what could have been a difficult primary reconstructive challenge into an extraordinarily complex salvage arthroplasty scenario.
Precisely. This reinforces the absolute necessity of rigorous acute assessment.
You must obsessively evaluate the medial hinge, the vascular predictors, and the degree of comminution before committing a young patient to an ORIF.
Right. If the fracture is genuinely unreconstructible and the biology is doomed, you must have the difficult, transparent conversation about primary arthroplasty, even in a younger demographic.
To actively avoid this exact biomechanical nightmare.
Yes.
Now, the physiological reality of osteoporotic bone, diminished osteoblastic healing capacity,
Yeah.
and lower systemic functional demands of the over 75 demographic completely inverts the treatment algorithm, doesn't
It
it?
does. It flips it entirely.
While anatomical preservation is the holy grail for the under 60 cohort, the severe biological limitations in the elderly shift the focus entirely toward immediate, reliable joint replacement.
Right. The acute arthroplasty landscape is dominated by the choice between anatomical hemiarthroplasty and reverse total shoulder arthroplasty.
And the evolution of primary arthroplasty for acute trauma over the last 2 decades is just staggering.
It really is. Historically, the algorithm dictated a hemiarthroplasty for nearly all unreconstructible fractures in the elderly.
But the historical results of primary hemiarthroplasty for trauma were notoriously unpredictable. It was essentially a coin toss.
Yeah, a massive gamble.
One patient would achieve brilliant, near-normal forward elevation and return to golf, while the next patient, with the exact same implant and the exact same surgeon,
Would develop profound pseudoparalysis and fail to lift their arm past their waist.
But the literature eventually revealed that hemiarthroplasty is not merely a gamble. It is dictated by a highly specific, controllable biological variable.
Yes. It is entirely predictable if you adhere to the biological rules.
Let's talk about the definitive criteria established by Pascal Boileau in the early 2000s.
Ah, the Boileau factor.
Yes, the Boileau factor demonstrates unequivocally that anatomical healing of the greater and lesser tuberosities to the humeral shaft is the single most critical determinant of functional success in a trauma hemiarthroplasty.
Right. The mechanics of this require detailed explanation.
Why does the healing of the metaphyseal bone fragments dictate the success of an operation designed to replace the articular surface of the joint?
Well, a hemiarthroplasty fundamentally relies on the patient's native rotator cuff musculature to provide the dynamic force couples require to elevate and rotate the arm.
Right.
The tendons of the supraspinatus, infraspinatus, teres minor, and subscapularis insert directly onto the greater and lesser tuberosities.
And in a severe 3 or 4-part fracture, those tuberosities are completely avulsed.
Exactly. So during the hemiarthroplasty procedure, the surgeon cements the metallic stem into the diaphyseal canal to replace the head.
Right.
But they must then painstakingly reconstruct the shattered tuberosities around that metallic prosthesis and the proximal bone graft.
The surgeon is attempting to coax devascularized osteoporotic bone fragments to heal to a smooth metallic stem and the diaphyseal cortex,
Right.
all while counteracting the immense continuous pulling forces of the rotator cuff muscles.
It is a profound biological and biomechanical challenge. The vectors are incredibly hostile.
The supraspinatus exerts a massive superior pull.
The subscapularis pulls anteriorly, and the infraspinatus pulls posteriorly.
They're all pulling in different directions.
Exactly. If the surgical fixation of those tuberosities is anything less than perfect, if the surgeon fails to use heavy, non-absorbable cerclage and horizontal tension band sutures, or if they position the prosthesis at the incorrect height or retroversion angle, the continuous muscle traction will cause the tuberosities to migrate superiorly or resorb entirely.
And if the tuberosities fail to achieve bony union, The rotator cuff has no functional attachment point.
The force couples are destroyed.
The patient inevitably develops anterosuperior escape.
Yes. The humeral head migrates upwards against the acromion, resulting in pseudoparalysis.
The operation is a catastrophic functional failure, despite the radiograph showing a perfectly cemented, shiny metallic stem.
Right. This inherent biological unreliability explains the massive paradigm shift towards reverse total shoulder arthroplasty in the acute trauma setting for the elderly.
Because relying on fragile, comminuted osteoporotic tuberosities to heal perfectly around a prosthesis was simply a bridge too far for the biology of an 80-year-old.
It was. The introduction of the RTSA into the trauma algorithm dramatically altered the landscape.
It has decisively become the standard of care for patients over the age of 75.
Or any patient presenting with profound osteopenia and highly comminuted tuberosities that simply lack the structural integrity to hold a suture.
Now, the biomechanical brilliance of the RTSA lies in the Grammont principles, established in 1985.
Yeah, Paul Grammont was a visionary.
How does this specific implant geometry solve the insurmountable problem of tuberosity non-union?
The RTSA succeeds because it fundamentally relies on altered biomechanics rather than perfect biology.
Right.
Grammont designed a system that reverses the native anatomy. We implant the convex ball, the glenosphere, directly onto the patient's native glenoid socket, and we implant the concave cup on the proximal humeral stem.
And this specific geometry accomplishes two critical biomechanical feats. It shifts the center of rotation significantly medially and inferiorly.
Exactly.
And by medializing the center of rotation, the moment arm of the deltoid muscle is dramatically increased, tensioning the fibers and increasing their mechanical advantage.
Precisely. The deltoid is recruited to compensate for the absent or non-functioning rotator cuff.
That is just brilliant.
It is. The altered kinematics allow the intact deltoid muscle to actively elevate the arm, completely independent of the rotator cuff.
Therefore, in the acute trauma setting, even if the tuberosities completely fail to heal and resort entirely,
Right.
the patient will still maintain the ability to actively elevate their arm above their head to perform essential activities of daily living, relying purely on the biomechanical advantage given to the deltoid.
The functional reliability is staggering. You completely bypass the biological wildcard of tuberosity osteosynthesis.
It is a highly pragmatic solution.
It is. If the tuberosities do happen to heal around the reverse prosthesis, which we do attempt to facilitate with meticulous suture techniques, the patient benefits from improved active external rotation provided by the infraspinatus and teres minor.
But if the biology fails and the tuberosities resorb, the primary goal of forward elevation is preserved by the reverse geometry.
Exactly. For an elderly patient whose primary requirement is functional independence to maintain their living situation, the predictable biomechanics of the RTSA make it vastly superior to the biological gamble of a hemiarthroplasty.
The decision matrix is clearly stratified then. Over 75 years of age, or presenting with profound tuberosity comminution and poor bone stock, the RTSA is the reliable, definitive intervention.
Right.
For the younger, high-demand patient where joint preservation is biologically impossible and primary arthroplasty is unavoidable, a meticulously executed hemiarthroplasty remains viable, provided the surgeon masters the strict technical requirements of anatomical height, precise retroversion, and rigid tuberosity fixation.
Yeah.
However, despite the most rigorous adherence to these algorithms, the most careful preoperative planning, and flawless surgical technique, primary procedures fail.
Unfortunately, they do.
We encounter recalcitrant non-unions, profound avascular necrosis, complete tuberosity resorption, and devastating deep infections.
Yeah.
This reality forces our discussion to the most complex and hostile surgical environment, the salvage scenario.
Salvage reconstruction represents the absolute dark frontier of shoulder surgery.
It really does.
Huh.
Managing a failed primary proximal humeral intervention, particularly executing a salvage reverse total shoulder arthroplasty in a younger, high-demand patient, is fraught with immense technical difficulty, massive complication profiles, and significantly diminished functional expectations.
It's a nightmare.
Detail the sheer surgical reality of this situation for us. Consider a 58-year-old patient who initially underwent open reduction and internal fixation with a locking plate for a 4-part fracture. The biology failed. They developed severe AVN. The humeral head collapsed. The titanium locking screws cut out and obliterated the glenoid cartilage.
Right.
Or consider the patient who received a hemiarthroplasty, where the tuberosity repair failed, leading to massive superior migration and pseudoparalysis.
Yeah.
When that patient is placed on the operating table for a salvage reverse arthroplasty, what specific anatomical horrors are you facing upon opening the delta pectoral interval?
To accurately grasp the magnitude of the challenge, we must look closely at recent outcomes data that rigorously analyze the technical hurdles and survivorship of salvage RTSA following failed primary fracture fixation.
Right.
The moment you make the incision, you realize that all normal anatomical landmarks are completely obliterated.
Everything's just gone.
The pristine tissue planes that guide a primary surgical approach simply do not exist. They are entirely replaced by thick, dense, unyielding fibrotic scar tissue.
And the neurological risks are exponentially magnified.
Oh, massively.
The axillary nerve, which is the sole motor supply to the deltoid muscle, is frequently encased within that dense scar tissue, often tethered directly to the inferior capsule or the conjoined tendon from the previous surgical trauma.
The axillary nerve is in extreme peril. Because the RTSA relies entirely on a functioning deltoid, any iatrogenic injury to the axillary nerve during the arduous neurolysis phase of the approach immediately guarantees functional failure of the salvage implant.
The dissection must be painstakingly slow.
It takes hours sometimes, but once the scar tissue is finally resected and the joint space is accessed, the true magnitude of the disaster is revealed.
Which is?
Catastrophic multiplanar bone loss.
The proximal humerus is frequently entirely absent, having been resorbed by the AVN process or physically destroyed by the loosening of the primary implants.
Right. And the glenoid vault, which must support the base plate of the reverse system, is often severely eroded, asymmetric, and sclerotic from the continuous grinding of exposed titanium screws.
Achieving rigid, primary mechanical fixation of the heavy RTSA implants in the presence of massive osteolysis requires highly advanced reconstructive techniques.
It does.
On the glenoid side, how do you secure base plate when the vault is effectively destroyed?
Glenoid fixation is the primary limiting factor for long-term survivorship in the salvage setting.
Right.
If the vault is severely compromised, standard base plates will fail catastrophically. The surgeon must employ massive structural bone grafting techniques such as the bio-RSA approach, using autograft or femoral head allografts to build a foundation.
And in cases of uncontained severe defects,
We are increasingly relying on custom 3D printed patient-specific glenoid base plates with augmented pegs and extended flange technology to achieve stable fixation in the remaining viable scapular bone.
incredible. But the humeral side presents equal, if not greater, challenges.
Absolutely.
If the proximal metaphysis is absent, a standard humeral stem has no supportive bone to prevent immediate subsidence.
The humeral reconstruction frequently demands extreme measures. You cannot rely on standard diaphyseal stems.
Right.
The surgeon must utilize extremely long, cemented revision stems to bypass the proximal defects.
And what if the proximal bone loss is just profound?
In those cases, we frequently have to utilize an allograft prosthetic composite, or APC.
Right, NPC.
This involves taking a massive structural cadaveric proximal humerus, machining it to fit the patient's remaining diaphyseal bone, and cementing the long revision stem through the allograft and into the patient's canal.
That is a massive undertaking.
It is. This complex construct replaces the missing proximal bone stock and, crucially, provides a biological scaffold for the remaining soft tissues and tendons to adhere to.
But beyond the sheer mechanical challenge of the bone loss, we must consider the physiological state of the deltoid itself.
A huge, often overlooked factor.
Right. If a patient has endured a primary injury, an initial deltoid splitting approach, a subsequent delta pectoral approach for hardware removal, and months of painful altered kinematics, the deltoid muscle itself is profoundly traumatized.
The physiological impairment of the deltoid is a massive variable explicitly highlighted in recent outcomes data.
Right.
The RTSA is a deltoid-dependent procedure.
Exactly.
If the deltoid muscle is heavily scarred, atrophied from prolonged disuse, or partially denervated from multiple previous surgical insults, even the most perfectly positioned, biomechanically flawless reverse construct will yield poor functional results.
The engine driving the new mechanics is fundamentally compromised.
Spot on.
Setting realistic expectations for the patient is paramount. If the surgeon successfully navigates the hostile scar tissue, protects the axillary nerve, rebuilds the glenoid vault with custom implants, and successfully implants an APC to reconstruct the humerus, what is the realistic functional trajectory for that patient?
The primary and often only guaranteed victory is pain relief.
Right. Just stopping the grinding.
Exactly. The salvage RTSA is highly effective at eliminating the agonizing mechanical grinding pain of the failed primary surgery. However, the functional expectations must be drastically tempered.
They will not be playing tennis.
No. The outcomes of salvage RTSA are universally and statistically significantly inferior to the outcomes of a primary RTSA performed for acute trauma or primary cuff tear arthropathy.
The patient's active forward elevation will be markedly limited, their external rotation power will be severely diminished, and their long-term complication rate is terrifyingly high.
Including postoperative instability, deep paraprosthetic joint infection, and paraprosthetic humeral fractures.
This serves as an incredibly powerful, sobering endpoint.
It really does.
The stark reality of the salvage environment brings this entire discussion full circle. It forcefully reinforces the fundamental premise established at the very beginning of this analysis.
Yeah.
The sheer magnitude of the salvage nightmare is exactly why the initial, acute management decision requires such rigorous, evidence-based, obsessive assessment. You cannot simply apply a locking plate and hope the biology cooperates.
The pathway to a catastrophic salvage reconstruction is invariably paved with poorly indicated, mechanically flawed primary surgeries. When evaluating that initial acute trauma radiograph, the surgeon must project the biomechanical and biological timeline 5, 10, and 15 years into the future.
If the physiological indicators suggest a high probability of primary failure in a 60-year-old patient, the treatment strategy must be radically reconsidered immediately.
Specifically to prevent that patient from becoming a devastating salvage statistic.
This analysis has navigated an incredibly complex, high-stakes clinical landscape. Let us crystallize this extensive discussion into the definitive core clinical pearls that you, the listener, can immediately integrate into your acute trauma assessments and operative planning.
Excellent.
Number 1. The most critical decision is the first one. Executing the correct initial management strategy prevents the devastating cascade into the salvage reconstructive nightmare.
Absolutely.
Number 2. Hertel's medial hinge is the absolute vascular compass. Measure the metaphyseal extension, evaluate the medial periosteal sleeve, and allow those variables to dictate your assessment of the joint's biological viability.
Spot on.
Number 3. The Proffer trial provides vital-level occasion evidence supporting conservative management, but it absolutely does not apply to the most complex, severely displaced, or mechanically uncoupled fracture patterns. You must treat the specific mechanical disruption of the patient, not blindly adhere to a population-level abstract.
Quite right.
Number 4. When executing a hemiarthroplasty, respect the profound importance of the tuberosities. Their rigid anatomical osteosynthesis and successful biological union entirely dictate the functional success of the procedure.
Indeed.
And number 5. For the under 60 demographic, aggressively pursue joint preservation with meticulous, biologically respectful, and mechanically sound open reduction and internal fixation whenever the anatomy permits.
Excellent summary.
If this rigorous evidence framework helps you navigate the complexities of your next trauma board or provides clarity when templating a difficult case, please take a brief moment to rate and share Deep Dive Ortho with your colleagues.
You know, we have spent decades intensely debating the precise mechanics of lateral locking plates versus diaphyseal intramedullary nails, refining the geometry of locking screw trajectories, and modifying the biomechanical parameters of arthroplasty implants.
We have.
But as we look toward the inevitable future of orthogeriatrics and complex upper limb trauma, one must fundamentally question whether the next monumental leap in proximal humeral fracture management will come from yet another iterative piece of titanium, or rather from targeted, highly specific pharmacological interventions, localized biologics, or parathyroid hormone analogs that artificially accelerate and virtually guarantee reliable tuberosity and metaphyseal healing within that critical, fleeting, acute window.